Hello everyone, I am Dr. Aditya from the Shoulder and Knee Clinic at Dr. H Hiranandani Hospital. So let's talk about shoulder dislocations today. So shoulder dislocation is a very common problem, and I'm sure a lot of us would be aware of somebody in our distant relation or friend who has had a shoulder dislocation and has got treated for it. To understand the shoulder dislocations, you need to understand the anatomy of the shoulder. So it's a ball and socket joint. This socket is a flat socket and the ball is round. So inherently the joint is unstable. To give it stability, there are tissues around the shoulder like the labrum which increase the depth of the socket. So it's like a rolled up towel around the socket which increases the depth. Then there are ligaments which help in stabilizing it, and then obviously there is the rotator cuff musculature around your shoulder which helps in stabilizing it. How does shoulder dislocation happen? Typically, there are two categories of shoulder dislocators. So one is individuals who have had significant injury to their shoulder, like they fell down on an outstretched hand or the hand was in this kind of a position, and then they heard a pop in the shoulder and they had a lot of pain and deformity of the shoulder. So that's the typical mechanism of shoulder dislocation. So this is called a traumatic shoulder instability. The second variant is an atraumatic instability. So if you see around you, you will definitely find one of your friends or somebody who is more flexible compared to the others. Now, when I mean flexible, obviously not mentally, what I mean is the joints are more flexible. So they are able to, touch their thumb to the forearm. They are able to hyperextend their elbows. So these are individuals who have hyperlax joints. These are the second group of individuals who tend to dislocate their shoulders. Typically in them, there is no involvement of a high energy trauma or something like that. As their age progresses, they keep on dislocating their shoulder without any inciting trauma. Sometimes they dislocate the shoulder voluntarily also. So this is the second spectrum of disorder known as atraumatic shoulder instability. So when we consider a traumatic instability, typically there is a ligament tear here in the front of the shoulder, as a result of which the shoulder dislocates. So this is what we call as an anterior shoulder instability or a Bankart lesion. There are other varieties of shoulder instability which happen due to injury, like a posterior instability where the shoulder is dislocating posteriorly or moving posteriorly, causing pain in the shoulder. And this is a separate topic altogether. So today we are just going to discuss the anterior shoulder instability. Obviously, the other spectrum of disorders which I told about, a non-traumatic shoulder instability, that is another wide discussion altogether, and that again we'll take a separate video for that. So coming back to the anterior shoulder instability or the Bankart lesion. So typically in a traumatic shoulder instability or the Bankart lesion, there is a labral tear, that is your labrum is torn from 3 to 5 o'clock position of your shoulder. So this is your socket and typically it is referenced of the clock face. So from 3 to 5 o'clock there is a ligament tear, your shoulder dislocates out like this when you take your hand out in this kind of a position. So that can be like when you're playing badminton or you're doing a smash or you're reaching out for the top shelf to remove certain things. Studies have shown the relative risk of an individual dislocating the shoulder to a large extent depends on the lesion as well as the age of the individual. So if the age of the individual is less than 20, there is 100% chance of the shoulder dislocating again. So that can happen within 6 days, within 6 years or 6 months. That is something unknown. As your age increases, after the first episode of dislocation, the risk of redislocating the shoulder decreases. So somebody who is 20 years of age who has dislocated his shoulder for the first time is at a very high risk compared to a 50-year-old person who has dislocated the shoulder. And accordingly, the treatment is also different. Treatment in a younger individual who is active, especially below the age of 20, is generally surgical because of the higher risk of redislocating the shoulder. The number of man hours lost due to morbidity in treating it non-operatively is far more compared to addressing it surgically and having a faster recovery. So that is a topic which is up for debate, but at our center we treat younger individuals more aggressively, and in younger individuals less than 20 years of age, definitely we recommend surgery even for first time dislocators. As your age increases, then comes the scope of a non-operative treatment. So non-operative treatment after first dislocation generally is reserved for individuals above the age of 30, because the risk of them redislocating their shoulder is around 50% compared to somebody below the age of 20 where it's nearly 100%. The other pathology which can influence the treatment is whether it's just a ligament tear or is it a bony Bankart. So what's a bony Bankart? So essentially a Bankart lesion is there where there is a ligament tear from 3 to 5 o'clock and just the ligament is torn. Whereas a bony Bankart happens when the bone comes off with a piece of the ligament. So this is very important, because if a bony Bankart is not managed operatively, there is a very high risk of redislocating the shoulder. Because let's say this is the socket. So typically the size of this socket in Indians is around 28 millimeters. So even if we remove, let's say 8 millimeter of bone, which is around maybe 10 to 15%, it's a significant portion you are removing. So it significantly decreases the shoulder stability. Operative treatment for shoulder instability essentially consists of a keyhole surgery or an arthroscopy. So the advantage of an arthroscopy is it is done through very small cuts around your shoulder. Cosmetically it is good and it gives a faster recovery. So typically the next day of the surgery you can be discharged, and you'll need to do physiotherapy to gradually recover the strength and function of your shoulder. So appropriately done, a surgically repaired Bankart lesion or a bony Bankart lesion has a very low risk of recurrence. It's very important to understand the pathology and address it. So the most important thing when we decide regarding this is whether there is a bony lesion or not. Due to recurrent episodes of dislocation, generally there is a wear of the socket and a hole develops here. So the wear of the socket is known as glenoid bone loss, and the hole that develops in the ball is known as a Hill-Sachs lesion. If the bone loss is significant, then just doing a ligament repair does not help. In those scenarios, what we do is bone augmentation through a procedure known as a bone block cerclage, which increases the bone here, and in addition to that we do a ligament repair. If the hole here is significant, the Hill-Sachs lesion, then we address that through a repair. So there are multiple arthroscopic surgical options available to treat shoulder instability. It essentially depends on the significance of the ligament injury as well as whether there is presence of bone involvement in that. Arthroscopic shoulder stabilization has developed over the last 10 years and has given excellent results in these kind of injuries with very low risk of recurrence. Now, shoulder instability is a very big topic and we'll keep on discussing this. This is just a brief overview. So we'll keep on discussing about this, and in the subsequent videos we'll describe various procedures we can do for shoulder instability in more detail and the other varieties of shoulder instability. So stay tuned in, and if you like our content, do subscribe and share our channel. Thank you.